Well, first, let me thank the course directors for inviting me to participate in this fellows course and the main course. I'd just like to reiterate how spectacular this course is. I was sitting in these seats 9 years ago, and then again 8 years ago, and attending this endoscopy course was really just a wonderful experience back then, and really helped me crystallize my decision to pursue advanced endoscopy and so really it's a pleasure to come back here as a speaker and a faculty member. So well, let's get started. Subepithelial lesions. I mean, this is an interesting topic. I'm glad that this was selected for the fellows course. Um, Being an endosonographer, in a way, will obligate you to become an expert in certain facets of gastroenterology, and I think this is one of them. A lot of your colleagues who don't necessarily perform EUS will only see these patients in cross section or will encounter them infrequently. But because of your skill set with EUS, your practice will be enriched with these patients with these types of findings. So it's important for you to really develop an algorithm and an approach, especially from a diagnostic standpoint for subepithelial lesions. Sometimes I joke with my trainees and my colleagues that it feels like sometimes I'm the director of gastrointestinal lumps and bumps. Um, but I'm glad that this topic was selected, and certainly it's an important dimension of gastroenterology to have an algorithm for. So let's start with what is a subepithelial lesion. So I think most of us would agree it's a protruding elevated lesion with normal overlying mucosa. Now that being said, it's not infrequent where I will have a patient referred to me for EUS with a subepithelial lesion where there is actually a mucosal component. But if we're going to be strict with the definition, I think this is probably the most important aspect of this. It can be found within any segment of the luminal gastro. They can be found anywhere in the luminal gastrointestinal tract, and they're most often found incidentally. That's the most common circumstance for the patient with one of these findings will be sent to you. The incidence rate is up to 0.3 to up to 1% on upper and lower endoscopic diagnostic studies. And really what you're doing with with these lesions is trying to narrow a very broad differential diagnosis. And the first thing that you want to start, something may be subepithelial, but you really want to try and figure out, is it indeed intramural? And then based on perhaps the endoscopic images, and we'll talk about the importance of doing your own endoscopy before you move on to EUS in these patients. Is there a mucosal component? If yes, were mucosal biopsies performed? And you really want to look at those biopsies because sometimes you already have the diagnosis when this patient comes to you. And speaking of that, reviewing the cross-sectional imaging in these patients before you perform an EUS procedure, before you move forward with that evaluation is very important. A non-insignificant proportion of these patients, that subepithelial lesion that was sent to you is actually extramural compression of the foregut by a juxtaposed organ or a juxtaposed abnormality. So when you're looking at CT scans or MRI scans, anything that was done in this patient, you want to ascertain, is there regional lymphadenopathy? Is there a juxtaposed vascular abnormality or vascular abnormalities like an aneurysm or varices? Is this patient, maybe you don't have imaging, but this patient has significant risk factors or a history of pancreatitis. This could be a pseudocyst. So really, you want to hunt down that cross-sectional imaging before you embark on that diagnostic algorithm. Because cross-sectional imaging studies, even for an intramural lesion, can be diagnostic if the lesion is greater than 2 to 3 centimeters. Lipomas, GISTs do have some distinctive radiographic characteristics. So you may already have a diagnosis before you even perform an endoscopy in this patient to ascertain the subepithelial lesion. If it is indeed intramural, your differential diagnosis to begin with is quite broad. The good news is the majority of these are benign lesions, and that's some reassurance that maybe you can give the patient up front when you're consenting them for the procedure. Any of them are quite anxious whenever they're seeing you and they find out that there's something in the lining of their stomach or colon that is described as a mass or a nodule. I have the list of differential diagnosis here, which is quite broad, but it spans solid lesions, cystic lesions, vascular abnormalities, anatomic variants. But the thing that is very important, can help you narrow the differential diagnosis quite quickly, is it's the anatomic location of the abnormality. Um, So really, before you even perform an endoscopy in these patients, you want to review the cross-sectional imaging. You actually, if you can, you want to look at those endoscopic images, if they're available within your EMR, to look at the morphology of the lesion. Think about the layer of origin, and already you've taken a broad differential diagnosis of greater than 15 abnormalities, and you've been able to narrow it down to 3 or 4. And then the next step is EUS for many of these abnormalities. And based on the layer of origin at EUS, its characteristics, ultimately sampling, which has a very, with modern biopsy needles, has a very high level of accuracy. You'll be able to narrow the differential diagnosis down and off of, and verify that diagnosis. So in all these patients, I perform my own endoscopy up front, and I think there's a lot of value to doing that. Um, you may not have the best description or descriptors of the lesion based on the referral endoscopy. It'll help you localize it for whenever you perform the EUS. And you want to, with your own eyes, take a very close look with high quality white light endoscopy, as well as perhaps narrow band, to see if there's a mucosal component. And if there is, perform your own biopsies. And I think there's also a lot of value to external ballottement that will actually help you narrow the differential diagnosis. If it's something that's firm, it might be a gist or a carcinoid. If it's soft and fluctuant, that'll raise your suspicion that it's a cyst or a varix. If it's soft and indenting, that's something that we call pillow sign, especially if it has that, the lesion has that yellow hue. That'll increase your suspicion that it's a lipoma. I've got a picture here of a duplication cyst in the duodenum, very small cystic lesion that with external blotment, you can see the forceps are very clearly indenting the lesion and there's fluctuance there. And then for external compression, there's some clues to that. When you're advancing the endoscope, especially for foregut lesions, is the wall shifting over that abnormality? Is it more of a nebulous abnormality rather than a discrete lesion? And then where is the location? Something in the body, fundus is more likely to be the spleen, lesser curvature, maybe liver margin or an exophytic liver lesion, posterior gastric wall in somebody with risk factors or history of pancreatitis, pseudocyst, and the list goes on here. So you really want to think about that when you're performing the upper endoscopy. And that's why I like to do my own endoscopy, same session with the US. And then here's a EUS image of that cystic lesion in the duodenum. And then when you perform your US, you have a checklist, and it's very important that you document all of these aspects of your during your US exam. You want to describe the layer of origin, its size, its shape, the borders and margins, its internal characteristics with reference to echogenicity, texture, pattern. Is it vascular? Use Doppler to evaluate it. And then if it's something that ultimately requires resection, either surgery or endoscopic resection, and it's a foregut lesion, how, and it's in the esophagus or gastric, how close is it to the G junction? How far away is it from the anal verge? If it's duodenal, how close is it to the papilla? Is there lymphadenopathy or evidence of metastatic disease? From an EUS standpoint, technical considerations. So most of us will use radio echo endoscopes for several reasons. It helps us quickly localize the lesion, especially for, I would say it's especially, I would lead with this instrument if it's less than 15 millimeters in diameter, because it could be a little bit difficult localizing it, even if you're using a traditional endoscope beforehand. A linear echo endoscope is going to be, you're going to need that in order to perform sampling. You can consider leading with that if it's a very large lesion and you feel very confident you're going to perform F&B. Processor settings, ideally in order to ascertain layer of origin and ultrasound characteristics, you want to be at about 7.5 to 10 megahertz when you're evaluating it. Sampling aspiration has a pretty, needle aspiration has a decent performance with reference to accuracy, but really what we're doing now with modern biopsy needles is performing F&B, and a recent analysis has shown that F&B performs quite well over FNA in terms of superiority in terms of adequate sampling, higher likelihood of diagnostic accuracy, and fewer passes to obtain a diagnosis. So really we're using F&B needles for these lesions. And then selecting the needle diameter for lesions less than 10 millimeters, it can be very hard to cut with a large 22 gauge core biopsy needle. So oftentimes I'll try with a 25 gauge needle and see if I can get a diagnosis using that smaller needle. And then something greater than 10 millimeters, you can lead with a 22 gauge. And if you're using a core biopsy needle, it's very rare where if I had to use a 19 gauge needle on those patients. So this is for your review layer, but this emphasizes the point that the layer of origin really narrows down the differential diagnosis. Again, you're taking this list of 15 different lesions and you're very rapidly decreasing it to a handful of lesions. And when you pair that with the ultrasound characteristics of the abnormality, of which there are some distinctive ones, and the location within the gastrointestinal tract, I think you're able to already, before you even perform F&B, narrow that differential diagnosis down to about 2 or 3 lesions. So beyond F&B, if you're still struggling to make a diagnosis, what sort of advanced sampling techniques are available for subepithelial lesions? So, you can perform bite-on-bite tunnel biopsies. However, the yield tends to be very low. And really, I would only consider this in patients who I feel that there's likely a mucosal component, or if there's an ulceration where you can seed the forceps within that ulceration and get at the deeper layers, at the lesion in the deeper layers. And sometimes you'll have that opportunity, but rarely. There's been case reports and case series of the single incision needle knife technique or sink technique having a high diagnostic accuracy. It may be more advantageous for smaller lesions or when there's significant intraluminal growth, there's a significant bulge to that lesion. But really, we lead with F&B, and F&B, when you select the right needle and have good technique, oftentimes you can make the diagnosis utilizing US F&B. And then there's advanced resection techniques, which have diagnostic utility if you're failing to make a diagnosis with F&B, but also are tools that we have in order to manage these lesions. And getting into the granular details of these techniques is outside the scope of this talk. But which technique you use will dictate the layer of origin. Again, that's where layer of origin is very important on a US. So submucosal, mucosal, mostly mucosal, and to a lesser extent submucosal lesions, you can consider endoscopic mucosal resection. Ideally, it's done for lesions less than 2 centimeters. Examples would be carcinoid granular cell or perhaps even pancreatic rest. You can consider band EMR technique to really get a better resection. Once you're getting into lesions that are mostly submucosa and to a lesser extent muscularis propria, you're looking at ESD or submucosal tunneling. And with those lesions, you run a higher risk. Well, you'll have a higher likelihood of complete resection. You have a higher risk of adverse events or semi-intentional or semi-intentional perforation. And then finally, there's endoscopic full thickness resection techniques where based on the size of the lesion, you can use a full thickness resection device or you can use freehand full thickness resection. And you have a very high rate of en bloc resection, but you're essentially making an intentional perforation. So you have to be prepared and trained in order to perform closure techniques in these patients, especially if you're doing a freehand. So there's many different ways to cut the pie, so to speak, or design an algorithm around these lesions. The way that I conceptualize it is the lesion in the deep mucosa / submucosa. If the lesion on EUS has benign features or is clearly vascular with Doppler flow or has distinctive features of a lipoma, then I don't think those patients need any further workup. If it's deep mucosa and if F&B is feasible, usually these lesions have to be greater than 8 millimeters, and you perform F&B. If F&B is diagnostic, then you've made your diagnosis, and then you have to think about what exactly the lesion is for the management algorithm. And based on pathology, US characteristics, symptoms, interval growth, patient candidacy, you can consider endoscopic mucosal resection or ESD for those lesions. Or referral to a surgeon for resection. If the lesion is not feasible for the lesion to perform F&B and based on its ultrasound characteristics, you'll either put those patients into a surveillance program to see if they graduate into a higher risk lesion. Is the lesion growing? Is it developing new characteristics that raise your suspicion? Or does it get to a point where you can perform F&B? The other algorithm is for lesions that are from layer 4 or muscularis propria. So again, you want to consider its size, its EUS morphology. Lesions greater than 8 to 10 millimeters, you can most often perform F&B. Less than 8 millimeters, you may be able to do it with a 25 gauge needle. Do you get a diagnosis? Yes. If you don't, a lot of times we'll surveil those patients with the assumption that it's a leiomyoma or a GIST. And then, of course, if based on its size, its ultrasound characteristics, what the pathology shows, you may have to refer these patients for surgery or endoscopic techniques, advanced endoscopic techniques for resection. And again, there's a lot of layers, things that go into your decision making, surveillance versus resection. Not only, if you have a small lesion that's a layer 4 lesion, the endoscopic burden may not be high if these patients are coming back for Barrett surveillance or they have multiple polyps on colonoscopy, and you can embed that endoscopic ultrasound with their other surveillance endoscopic studies. How young are they? That's another question, for many of these lesions, even just if they're 3 centimeters, but the patient is 70 years old and they're on 3 liters of oxygen, you may not want to send these patients for resection and or consider endoscopic resection. So those are the other things that fall into your decision making, I think bear mentioning. So that's the conclusion of my talk. Um, uh, Again, I think this was a very appropriate topic. Any of us endosonographers will be encountering these lesions and have the expectation that you're going to have to cultivate some expertise in subepithelial lesions. So,
Thanks.
okay.
Thank you, Jeff. That was great. We do have Q&A at the end of the first group of lectures, so we'll keep the questions for that. So it is my pleasure now to introduce our next speaker, Dr. Mohammed Othman, a good friend, a national and international expert in interventional endoscopy, especially third space endoscopy. And he is professor of medicine at Baylor College of Medicine in Houston, Texas. And he'll be talking to us today about EUS tissue acquisition of solid lesions. Thank you.
All right. Thank you so much. I was in the same boat. Yeah, 2009, I was here as a fellow, and this is how I decided to become an advanced endoscopist, attending this course. So thank you all for being here, and I think it will be an amazing course. And I never get impressed every time I come to this campus in Colorado, how beautiful and wide it is. Even coming from Texas Medical Center with all these hospitals next to each other, you just love this campus. It is very nice, relaxing, organized. I wish Houston was that organized, but it's not. Like represents the chaos you see in front of you. Yes. So for tissue acquisition, that started by having the endoscopic ultrasound, the linear one, the EUS. As you know, how it developed initially, we had the radial. So we're just looking. And 1995 to 2000, what people used to do is that they just used to learn how to utilize EUS. And then linear came after that. If you trained with some of your physician who has been doing EUS from the beginning, you'll find that they were more comfortable using the radial than the linear. The new generation of advanced endoscopists are more comfortable with the linear more than radial. And the reason is this how you obtain tissue? The way I was trained, that we used to do radial first, then we'll go to linear. People stop doing that now. We'll just go right away and take the biopsy. So that's an example of how we obtain the biopsy. You have the portal vein, you have a mass, and under direct visualization, you can advance your needle within the lesion and avoid going into the stent or the bile duct or the portal vein. So in order to do that, we need echo endoscope. Color Doppler is important to avoid blood vessel aspiration. Needle, you have to have a lesion. And yes, sometimes people remove things or biopsy things that they shouldn't biopsies. Like a lot of time people can see things, they think it is something, but it's not. Don't biopsy small intestine when it's moving, for example. That's one of the things that people, so you have to make sure you have an intramural lesion. You have to know what's surrounding you, the organs, and then you will need cytology or histology, and we're going to talk about that now. So what are the techniques available to us now? We have the FNA, the standard one that we have been using for a long time in endoscopy and in other specialty too, like in thyroid and other, everybody use FNA. But then we have the FNB, fine needle biopsy. That's a new revolution. And then through the needle microforceps, and I just added the virtual biopsies, the NCLE. I know a lot of people are not excited about it, but I just would like to tell you a little bit of information about it because I feel it may have a comeback. So to make this interesting, I'm going to show you what we do as an advanced endoscopist doing EUSFNA because this is what we do every day. And I recall when I was trained at Mayo, we had 3 attending. Each one would do FNA in a different way. And then when it comes to my turn working with one of them, I really have to remember how he's doing it. Like Mike Wallace would like to push it hard and go and come back slow. And the other one would tell me, what are you doing? You have to go very slow. And one time I had to bring the 3 of them together and said, you have to agree on one technique to do this. They never agreed. So I would tell you this something is national and international, and you'll see right now going through the myth versus fact. We'll talk a little bit about role of stylet. So you know why we have a stylet inside the needle. If you see the FNA needle, you'll find that it has tiny, tiny stylet inside it. And that stylet is done to provide stiffness to the device and mainly to prevent the clogging of the needle with the digestive wall. What we mean by that, the stylet will block your FNA needle so that once you go inside the tissue, you remove the stylet and take the tissue. And the traditional teaching is that if you remove the stylet and you are going through the gastric wall, you're going to take gastric tissue through that needle and you're going to contaminate the specimen and you will not be able to obtain diagnosis. So why we have a stylet? To prevent contamination and prevent clogging of the needle. So rule of stylet, actually we don't have a strong evidence that stylet makes any difference. So stylet versus no stylet. This is a very large study, 236 patients in each arm. And they looked at the cellularity, number of cells per slide, adequacy of the specimen, contamination. And what's the main thing? We don't see any difference in contamination between stylet and no stylet. Who published this study? It's Professor Sashawani. He's sitting here. This was his one of the most beautifully done studies in that field, and it really made a difference. Makes people think about, you know what, we are always thinking of doing certain things certain way, believing that that's right. But when you really put it to a rigorous study, you discover that actually it is a myth. This is not real. So FNA needle. Each and every one of us will have a needle that we prefer. That's how it used to be. Now it's almost like the hospital will dictate certain needle and you based on contracts, but we're not going to talk about this. But in a way, the preference of one needle over another, you can ask one doctor, so why you do use this versus that, and he can give you a lot of reason. At the end of the day, it is a personal preference. It's all about the feel, the needle handle, and the ease of needle advancement, and that's how we get biased into the decision. How did I know that? 2012, I started this study looking at 3 different needle, and we looked at all of them, and it was randomized, and the pathologist was blinded, and he was doing rapid on-site evaluation on the site, and he wouldn't know which needle it is. And you can see here, cellularity score, quantity of blood, debris, inflammatory cell, neoplastic cell are all the same. So at that period of time, when we had these types of needle, now we have Easy Shot 3, expect is still the same, Procore is still the same, but really we did not find any difference. So basically, there's no superiority of one needle, of FNA needle over another. So then we're going to get to this exciting thing, the fanning technique. Some people say you should fan through the lesion. So if you can see here, this is a 2 centimeter pancreatic mass, and we're putting the FNA needle inside it. And you can see I have one trajectory, but you may be able to use your dials and elevator to change the direction of the needle within the lesion. So instead of going in the same track, you are guiding your needle to go in a different track little bit by little bit. We call that fanning technique. So in general, when we do standard, the studies were done like 10 and up to 15 to and fro movement. With fanning, you do this movement and you think that fanning will be superior to standard. Some people do fanning, some people don't. And do we have any evidence? We do. That's a very nice study. It was done in 2013 by Dr. Bang. I think she was in Florida at that time. And it was a small one, but they looked at the difference between fanning and non-fanning. And look here at the first pass accuracy. If you do the fanning technique, it is 85% versus 57%. At the end, you can take more passes and you get to the same result. So the diagnostic accuracy would be the same. But if you use fanning technique, you have a lower number of passes and high diagnostic accuracy of the first pass. So fanning technique is good. We should use it. Then the next thing, suction versus no suction. So when we advance the needle inside the mass, we usually put this syringe and it has suction in it. And the question is, should we apply this negative pressure or not? So the idea that if you apply negative pressure, you're going to get more tissue. But some people will say, but you're also suctioning more blood. So negative suction is associated with more blood. So there is this debate about that, and the debate saying that whether you use suction or no suction, it is the same. Is this really true or not? You can see here that in fibrotic lesion specifically, When you are not able to obtain sample, suction may work. If you have a lesion that's not fibrotic, like for example, pancreatic masses that's without fibrosis, suction may not do difference. So remember, suction will be important in fibrotic lesion. But then you will have something called slow pull technique. What is a slow pull technique? So instead of doing suction with large amount, you gradually get your stylet out little bit by little bit. The fact that you're pulling the stylet out little bit by little bit, you are introducing suction, but a small amount of suction. And that maybe would be something in between. You're doing suction, but also you're not suctioning too much. You'll have less blood. And that study looked at both of the slow pull techniques versus the standard suction technique. And you can see here that it's much better. Diagnostic accuracy was higher with a slow pull with fanning technique. So what we are getting here into slow pull with fanning is good. So far we are getting to know the FNA. Then rapid on-site, rows versus no rows. So it's allow real-time evaluation of sample adequacy. You will just ask your pathologist to be in the room, look at your specimens. They will never give you a final diagnosis, but they can tell you this is an adequate specimen. I think this is cancer. Don't get more specimen. The idea of doing that is that you are decreasing the number of needle passes. So instead of taking too many, you don't have to do that. You'll take as little as possible, and the pathologist there or the cytopathologist tell you that is enough. It's great. The exception is that it requires you to call the pathologist or cytopathologist every time you're doing the case. I was trained this way. I did it for 4 years, and I stopped. It is just like once you have a very busy practice, it become not. It doesn't. It is hard to do. So that was meta-analysis in 2012. They looked at 33 study, 4,900 patients. The pulse sensitivity of EOSFNA was rose, as we can see here, was 87 to 90%. Without rose is 78 to 80%. There's not a statistically different, but we can see with rose is slightly higher. However, there's other studies came after that showing actually that rose is not that different. And then this debate continued till something else came in the picture and it changed all of what we know about what we're doing, which is fine needle biopsy. So what is the difference between fine needle aspiration and biopsy? It's basically you're obtaining more tissue when you do biopsy. The design of the needle allowed to be a core needle that would obtain more tissue. So usually initially you're thinking that would be good for lymphoma or autoimmune pancreatitis. But then we learned that you can use it in practically every cancer, particularly pancreatic cancer. And now with individualized or precision medicine, they run a lot of immunohistochemistry stainings, and they likes to get more tissue to run the stainings on. And now we got to the question, FNB versus FNA. What do you use? What should we do? And we can see here, that's Dr. Burns' study, a meta-analysis from 2016, looking at FNB not that different from FNA in terms of diagnostic accuracy. But later on, we looked at FNB and rows versus FNA. If you don't have rapid on-site evaluation, FNB is as good as FNA with rapid on-site evaluation. But what's different about FNB is they give you even more tissue that you can just use enough, which is enough to evaluate for other things. So what we do at Baylor St. Luke's, we only do FNB needle. We send it in formalin. We don't do rapid on-site evaluation. Our standard is 2 passes only. We use fanning technique. And with FNB, you want to get as much tissue and you don't care about the blood anymore. Then we do suction. This was one of our trial that we did. What we did is that we looked at doing 2 pass. One pass that we're going to put in formalin, and the other pass we'll put in the regular cyto-rich media. And we tried to see if we just send your FNB specimen in formalin, would it be different or not? And we showed that it's not different. It's almost like obtaining a colon biopsy. Why this is important to send your specimen in formalin versus cyto-rich media? Because not every hospital will be a big university that they will have cytopathologists and pathologists. A lot of places they do everything by surgical pathology, so you need this formalin. So if you really simplify obtaining a specimen from the pancreas by sending it in formalin, you might discover that it is as good as doing cytology. And that's what we showed in the retrospective study. And then we're doing a prospective one to prove the same thing. So 2 passes, FNB, fanning technique with suction, Having said that, once you practice, it is all your style and you do whatever you think works for you. But that's what I think I would say the recommendation for it. So this is an example about FNV versus surgical biopsy. That's when I started my first job at Texas Tech University in El Paso. My mentor was a gastroparesis expert, Richard McCallum, and I couldn't find anything that we could work in together except doing FNV of the wall of the stomach to find the interstitial seal of Cajal. And our idea was that can we really get the interstitial seal of Cajal for research by doing FMV versus not doing FNV by doing surgery? At that time, they used to do full thickness biopsy, and they would do it at the time they do the stimulator. So this patient would have like a gastric stimulator, and that requires laparoscopy. And during the laparoscopy, they do full thickness biopsy, which I thought was crazy because you could just do the same with FNB. And when I told him that, he didn't believe me. So we did a study. So we do patient, and you can see here, this is what they do. Is even was open, and they would do the stimulator and take the biopsy, and they would look at the site of my FNB, and that was the site of the FNB here. So this was prospective non-randomized feasibility trial, and we showed that the fine needle biopsy is as good as full thickness surgical biopsy, and you can see the same number of interstitial seal of Cajal. So you don't need a surgery to do a full thickness biopsy of the wall. You can always do that by EUS. This was a few years ago. For us now, we say, "Duh, this is clear." But a few years ago, this was really a big debate. We'll go quickly through to the other thing is through the needle microforceps, and that's an example of how it works. That is a complex pancreatic cyst. You can see here it has many septa, and it's a little bit concerning because when you have a cyst that's not unilocular, like has multiple lobulation or loculation like that, many compartment, um, you worry about this cyst that it could harbor early cancer. So then you would like to, in addition to get the liquid and send it for DNA analysis and others, is also to obtain sample. Here we're showing how this microforceps work. You put this microforceps through a 19 gauge needle, you'll get very close to the wall, and you will obtain the biopsy, and you should see it coming closer to you when you're doing it. And we'll see right now when we're putting the microforceps, it's coming out, and now it will pull the wall towards it, and you can see the wall is coming back, and you can see the biopsy obtaining it under EUS guidance. And that was the actual case, and this was the actual pathology, and you were able to see really the cyst. And I would tell you, I diagnosed many neuroendocrine tumors by this cyst, and we had like good results. I am sure everyone here in the room using it, and we're getting good results. But what is the but here? We're seeing more bleeding, and there is a recent study published in Europe was one case of death from severe pancreatitis after using it. There was a nice editorial endoscopy by Doug Adler talking about it's a great device, but is it worth the risk? I really don't know the answer for that, but I'll tell you, I see the bleeding. I saw the bleeding happen in the cyst 1 or 2 times. I can see the cyst full of the blood, but it was never something that led to problem or the patient had pain. I think this case of death that was published was related to severe acute pancreatitis. I don't think anyone else has a death from using the device. I still use it, but I'm very cautious about using it in every case. But I think it is a great device and it helps. And it also can complement your FNB device. So in the study we did earlier, we found that even in cases when you're not able to obtain diagnosis, the thoracoscope biopsy would help, and the vice versa too. So when you combine both of them, you get diagnostic accuracy of 81%, and that's what's published in all studies in literature right now. So finally, virtual biopsy through NCLE, which is a confocal endomicroscopy. It has been around for a long time, ups and downs. People get interested in it and then they lose the interest. I will tell you, if you want to know the secret of your unit, just go in this storage room and you will find the confocal microscopy there somewhere in the back. Nobody's using it anymore, but everybody bought it a few years ago. We're thinking it would be the solution for everything, but we didn't. It was a little bit maybe earlier than the time. So the idea of it is that you can do a virtual biopsy, look at the lesion, and you can differentiate. As you can see here, this is a normal histology that's low grade in IPMN cyst, intermediate grade, and high grade. And what we are seeing here, the DNA content, the cells are replicating and increasing. We can see the same if we do NCLE. So you can see the difference between the high grade and low grade. It is much darker and wider. The papilla is wider. You can see here what we call clump. DNA clumps is dark, irregular, crowded areas versus the thin lines here. So that's what we see when we do NCLE. Obviously, the procedure is a little bit time consuming because you have to give fluorescent first and wait for it till it goes to the pancreatic cyst. But we're doing a trial and we have promising result combining it with other methods. And but I would say right now, virtual biopsies is still in the research phase and is not actually did not pick up to be something standard and should be done. So in conclusion, EUS FNA diagnostic accuracy is improving. EUS FNB could be used when ROSE is not available, and EUS through the needle microforceps yield promising result in pancreatic cyst. Thank you so much.
Thank you guys. Both have been excellent lectures.